In this video, we're going to talk a little bit about the Canadian healthcare system, and I will start this with just a clarification because it is a personal pet peeve of mine, and I think it's a really important distinction to make to sort of understand the place that we sort of play, the way that we sort of to integrate ideas about healthcare and sort of broader social and political things. So it's really common for people to say that Canada has free healthcare, and we don't. Canada doesn't have free healthcare. Canada has single payer or taxpayer funded healthcare. It's not that nobody pays for it. It's that we have decided as a society that it is more important to make sure that everyone gets access than to ensure that people get, pay only for the healthcare that they use. Okay, so that's my first thing. We don't have we have single payer healthcare or tax funded healthcare. We don't have free healthcare. Anyway, and I'm going to come back to the idea that we have not always had sort of single payer healthcare in Canada for a really long time. If you wanted healthcare, doctors weren't even regulated. Like in theory they were, but there was no formal standards and no real consequences if you didn't follow them. So we didn't have, for example, broad spectrum access. This is very much connected. You remember we were talking about sort of that idea of the epidemiological transition and how investments in public health are a big part of it. So, for example, when we started seeing that, regulating water quality, turns out that people get fewer waterborne illnesses if you treat the water properly. There's that kind of piece. And again, this is one of those artifacts of the post-war sort of after World War II era social welfare state. So part of the challenge, right, was that there was a desire to avoid the sort of extremes of the Great Depression where people were really, really suffering because of their lack of financial resources. So there was a desire to avoid people dying from otherwise preventable illnesses because they couldn't afford medication. So there's that part of it. There's also a big kind of broader social piece that is a little bit different, which is to say that in the post-war era, there were thousands and thousands and thousands of people. And sort of at a broad level, there was this sense of social victory, right? The victory, the end of the Second World War and conversations about ending the Nazi regime and sort of liberating concentration camps and sort of the end of that, right? Like, remember, at the end of the Second World War, everyone thought that was the last war the world was ever going to have. And so there was a sense broadly that the people who had fought that war, whether that was literally on the battlefield or sort of at home, sort of supporting troops and managing industry and growing grains and doing all that sort of stuff, that the people who had won that war deserved to live a dignified life sort of going forward. And that included not sort of suffering extremely in old age because you couldn't afford healthcare. So that's part of the reasoning that brought us to sort of single payer healthcare. It's also connected to the sort of development of a welfare state to begin with. So like our income guarantees and sort of income support payments and unemployment insurance come out of the same sort of era, which I think is really important to understand because we can't separate, right, these macro level socioeconomic, like these macro level healthcare things from the realities of like the sociocultural environment. So that's part of it. The Canadian healthcare system now, I will give sort of a brief structural piece in case I have students who didn't grow up in Canada or who didn't learn this in their sort of social studies classes. Technically, in Canada, healthcare is a provincial responsibility. So Alberta's healthcare system is distinct from Saskatchewan's, is distinct from British Columbia's, and so on across the country. In practice, the Medical Care Act of 1966, which is sort of the law at the federal level that creates the universal healthcare system in Canada, functions by essentially saying, okay, healthcare is a provincial responsibility, but the federal government is willing to give provincial governments a certain amount of money, and the federal government, generally speaking, has better powers of taxation. They get more money. That the federal government will transfer a whole lot of money to the provinces on the assumption that provinces agree to uphold the principles of the Medical Care Act, and those are identified in your book, but they are sort of universality in that you can't sort of refuse to cover people for whatever reason you feel like it. It doesn't matter if they're a little bit sick or a lot sick, you have to cover that. It needs to be comprehensive. So all of the medically necessary stuff needs to be covered. So you can tell someone, for example, that no, we're not covering your plastic surgery because you don't like how your nose looks, but you can't tell someone, oh, no, we're not covering the 15 hours of surgery that you need to recover, to sort of regain functioning after a car accident, because that is understood as necessary. Okay. We also have sort of public administration. So it's written into the law in Canada that healthcare is a public good. It is not intended to make a profit. So there's a requirement, for example, that people providing healthcare services, at least specifically when we're talking about sort of through the medical system and hospitals and that kind of thing, that they not have a profit motive. So they're not allowed to, for example, issue stocks. And because there's an argument that, and this is sort of a very conflict one, we'll get to that in our next video, but there's a very strong perception there that if you have a profit motive, then you're not likely going to be providing universal and comprehensive care. Relevant to the idea that healthcare is a provincial responsibility, one of the other principles in the Healthcare Act is portability, which is to say that because the money for healthcare in Canada in large part comes from the federal government, the idea is that, for example, Alberta cannot say, oh, well, you're supposed to live in you normally live in Manitoba, so we're not responsible for paying for your surgery or your necessary medical coverage if you get sick or seriously ill while you're visiting Alberta. So there's a responsibility that all of the provinces just kind of cover it. There is a way for Alberta to bill that sort of service back to Manitoba's healthcare system, but from a patient perspective, you never need to know that. That's all sort of handled on the back end. Okay. We've also sort of added this principle in the 80s about accessibility, which is really a recognition of just how important all of those social determinants of health are, because this is where we start talking about, for example, to cite a really specific Edmonton example, that's where we get the development of things like the Multicultural Health Brokers, which is an organization in Edmonton that provides cultural support in navigating the healthcare system. So this is not primarily nurses and doctors. This is groups of people like social workers who start talking about, hey, we have this racialized population or this ethnic population or this cultural group who doesn't seem to be accessing these healthcare services that we are pretty sure that they need. How do we make sure that that happens? And they do things like focus groups, and they sort of start talking about trying to understand the cultural context in terms of why people might not be accessing that. So this might be a language barrier. This might be concerns about sort of reputation and wanting to make sure that if I am, for example, a Muslim woman who wears the hijab or the burqa or the abaya, or the niqab, that I can see a female doctor and know that I can see a female doctor, instead of having to see a male one, which might sort of conflict with religious beliefs. So accessibility kind of comes in on that piece, and it also sort of raises the possibility. There's some doctors who are doing this in Ontario, that when you start talking about it, you can start talking about prescriptions. So there's some doctors in Ontario who work with really low-income populations who will prescribe more income as a health intervention. And this sort of principle of accessibility is sort of how they are able to justify that. Okay. We're in a state of transition in the Canadian healthcare system, partially because demographics are changing. So many of the programs, healthcare included, that were implemented in that post-war era were workable mostly because there were more people of working age than people who were elderly or people who were very young, i.e. there were more people to support the system than needed to draw on the system needed to draw significantly on the system. We're at a place where that is changing a lot, partially because the people who were born in that post-war baby boom are now starting to sort of become elderly, and they're starting to draw on the system, and the numbers just haven't kept up. So the cost of healthcare is going up, and not just necessarily because the population of Canada is going up, but the cost per capita is going up. So if you look at a lot of healthcare spending, I think something ridiculous like 60% of the spending, healthcare spending in a person's lifetime in many parts of the Western world is likely to occur in the last like 5-10 years of their lives. So an aging population is a really big part of that. But I will sort of offer another kind of more hopeful context in this, that part of that is about a philosophy, and that part of that is about how we understand that. So there's lots of research data out there that suggests that in our discussions, when we start talking about addressing health outcomes, sometimes there's a lot of argument to say that actually it's better to deal with the social determinants of health. So this is the argument behind a housing first strategy. So for those of you who are not familiar, the housing first strategy is a strategy for dealing with homelessness that argues that before we treat addictions, before we treat mental illness, before we do any of those things, you need to provide housing. And that you provide housing first because the stability from having safe and secure housing access makes treating addiction easier, makes treating sort of mental illnesses easier, and that providing housing is cheaper than than paying sort of the emergency room bills, because if you've never sort of understood that, emergency room medicine is among the most expensive medicine we can offer, because it tends to be the most acute, right? So if you have people in stable housing with relationships with doctors, then you're probably going to have a healthcare system that catches something before it becomes critical, right? So you might catch someone who's developing, I don't know, type 2 diabetes before they are sort of collapsing from like mismanaged blood sugars, because by the time that is happening, you're also likely dealing with sort of like nerve damage. You're dealing with a whole bunch of other things that are going to show up in the emergency room. So there's a lot of kind of conversation that if we shifted some of our healthcare dollars towards the public health side, towards the prevention side, towards the conversation around how do we build infrastructure that allows people to be physically active? What does it look like to ensure that communities are safe enough that everyone can go out for a run, right? We talked about sort of access to running as being sort of like socially determined. What does it mean to build neighborhoods that look like that? What does it mean to create zoning requirements to make it sort of more difficult to create food deserts and food swamps and easier to create food oases, right? So we can do that by, for example, creating zoning requirements that you can't have more than X number of fast food restaurants in close proximity to each other, to make it easier to zone grocery stores. Like there's all kinds of things that you could do in that space to sort of provide that. So part of the challenge about this transition in the Canadian healthcare system is largely about how we want to spend our money, whether we want to spend that money in terms of broad-based, sort of diffuse health promotion, or we want to spend it in treatment, with the recognition that the more you focus on solely treatment, not that treatment's not important, but the more you focus only on treatment, the more that treatment is likely to cost, because the prevention itself is cheaper.